Good afternoon, everyone, and thank you for joining our Utilization Management Summit on webinar on prior authorization. I'm Courtney Yo-Savage, Senior Vice President of Policy and Advocacy at the Cancer Support Community. Before we begin, just a few housekeeping items. Today's webinar is being recorded and will be available for viewing afterwards. You will receive an email in the coming days at the email address you provided when you registered. If you have any technical or administrative difficulties, please let us know by using the chat box at the bottom of the screen, and we'll do our best to address them. If you have questions, please submit them in the Q&A box throughout the presentations, and we'll do our best to get to them throughout the Q&A portion. Before we get started, I also want to take a moment to thank our sponsors for helping us to facilitate this important dialogue. Bristol Myers Squibb, GSK, Janssen, Novartis, and Sanofi. This roundtable is a part of CSC's Forum on Utilization Management, now in its 5th year. The forum was created to foster thoughtful discussions that engage a broad range of healthcare stakeholders and keep focus on patients. Ask tough and nuanced questions about when various approaches are acceptable and when they have the potential to harm patient health outcomes, as well as identify new and promising practices that optimize evidence-based healthcare. strategies are common policies which, when implemented appropriately in healthcare, can enhance the patient experience and improve quality of care. However, they can also negatively impact patient access to care and contribute to provider burden. Since 2019, CSC has hosted a quarterly roundtable on critical policies. CSC is committed to fostering conversations that inform and engage all stakeholders in the creation and implementation of strategies that include the patient perspective and incentivize cost efficiency through improved patient care and outcomes. We are all here today because we believe that we have a role to play in making high-quality healthcare accessible and available. And so I would like to introduce our expert panel of speakers today, representing the patient and caregiver and provider and policymaker perspectives. Christina Bach is an educational content specialist and psychosocial content editor at Oncolink and a CSC Helpline financial navigator. Dr. Chollet-Lipscomb is a radiation oncologist practicing in Nashville, Tennessee. And Peggy Tighe is a principal at Powers Law and an expert on prior authorization policy. As we get today's conversation going, I'd like to, I'll take a moment to explain our format, but we'd like to get some feedback from you all as we dive into the conversation. So Leah's gonna put up a polling question on the screen, and hopefully you all will just take a moment I think if there's an earlier one, what best describes you as a participant in the session? Well, please feel free to weigh in on that one as well. So we'll have 2 questions for you. Great, that's perfect. Just please take a moment and identify yourself, what the best description of you as a stakeholder in issues is. And because we have the benefit of some true experts this afternoon, we thought we would use the opportunity to pivot back to some of the original intent of these roundtable discussions, an open dialogue on the policy landscape from the perspective of different stakeholders, which is part of the reason why we hope that all of you will choose an option that best identifies you, or let us know if that doesn't work. So Leah, why don't you close that? Can we see the responses? Okay, great. So we have a lot of policy staff. We do have patient and caregiver perspective. We have some of our CSC network partners and other identified caregivers, and pharmaceutical industry staff. So that's a really diverse population. And part of what we wanted to emphasize here is the diversity of perspectives that come into play. I will note that we did not include payer staff, which we could have done and probably will in the future, to address some of the economic pressures from the payer side to contribute to that conversation. But acknowledging the diversity in all of our participants' background, and Leah, we can take that down, or folks can take that down themselves. I first wanted to invite Christina to sort of do some level setting for us on some of the terminology that we'll be discussing today so that everybody can be on the same page. Christina?
Great, thanks, Courtney. I think it's really important for us to all, like Courtney said, to be on the same page about the terminology that we're speaking about. And I also just want to remind everybody that even though we all come from a really different backgrounds, as we saw in the polls, we are also all still, every single one of us, consumers of the healthcare system. And so we also need to know this from our own personal perspectives. So I thought it was important for us to unpack what some of these terms mean. And I highlighted on purpose in red that prior authorization is a decision made by your health insurance company, not your physician, not the hospital where you're going for care, but absolutely 100% made by the payer. And in that decision, they are just saying that healthcare service, the treatment, the prescription drug, maybe the walker, the wheelchair that you need, or some other service is medically necessary. It is not in any way, shape, or form a guarantee of payment. So while we would like to say, hey, I got the prior auth, why is this now, this claim post the time I've received the service now being denied? Having that prior auth is helpful, but it's not necessarily a guarantee of payment, because the prior auth may not be looking at also some of the regulations within your actual individual plan saying this is or isn't covered, or you've already capped at this amount for the year. So remember that when you're thinking about, well, I jumped through all the hoops and I got the prior auth. Usually they are required before certain services. I'll use myself as an example. I've had to get multiple MRIs on my very old arthritic knees, and every single time they have to be prior authed. Despite the fact that I work for a large health system and get all my care at the same health system, it still has to be done. And I absolutely encourage all of us, again, we're all consumers of healthcare, to be sure that this work is done before you get in the MRI scanner. And I made that mistake once. I had not gotten a letter that said, and by the way, they do this a lot by letters still, so it's waiting in the snail mail. That said that this had actually been done. So really what I should have done was called my provider and say, did you get the prior auth? And what is the prior authorization number? Just for my own records to make sure it had been completed before I had the actual procedure. And sometimes this is called a pre-cert, a prior auth, a prior approval, or predetermination. Your plan may call it any number of things. Okay, we're ready for the next slide. So what happens if my prior auth isn't approved? It's denied. And it may be denied for any number of reasons. You can certainly ask what the reason is, but this is when the insurance company refuses to pay for services requested, ordered, or obtained. So again, obtained is key too. So you could already have had the service. When I worked in a large utilization management department here at Penn, we had lots and lots of services and entire hospital admissions that were denied after the patient was discharged for various reasons of documentation, coding, billing. So this can happen throughout the trajectory of receiving healthcare. And like I said, can be the result of paperwork or coding errors. So what can you do if something is denied? You can appeal. This is your opportunity, and I 100%. You have to do this with the partnership of a provider to ask your insurance to rethink the denial and pay for the service. There's two different kinds of appeals: internal, where you're going directly to the payer, and external, which is available when there is question about medical necessity, when and where you can get care, and what types of coverage you need if coverage is rescinded. Timing is really important for appeals. There are limits on the amount of time. I once had a claim of my own that 1.5 years later was denied because it was coded wrong. And because it was outside of the time when I could appeal it, I was on the hook for it. So it's really important for us to stay on top of some of the paperwork, especially if services have been denied. These also can take time for services to actually be approved during an appeal. Each payer, again, it depends at the local level, the state level, who's the payer. Is it a commercial plan? Is it a government plan? There's different rules for how long they have to give you for an appeal to be returned. So it's also important when you're reading the fine print in your policy. And if you haven't done that, that's another thing we all should be doing. You should understand the appeals process within your own insurance coverage. Okay, we can go to the next slide, Leah. Formulary. This is the list of preferred medications that are covered by your prescription plan. It's a moving target. It changes all of the time. This weekend, I tried to use the app for my own prescription drug management service, and the formulary seems to be some sort of secret. I can put in the names of the drugs that I'm trying to research, but there's actually no list on the app, which I think is actually a problem. If I'm sitting in the doctor's office and we're trying to say which medication might be the best place for me to start in terms of coverage when it comes to something like a PPI or something for diabetes, or, oh my gosh, a cancer drug that I may need to take. So those changes to formulary can be made at any time during the plan year. They change when a new drug is added. They change when drugs lose FDA approval. They change when costs, when patents run out and things become generic. It's all a moving target. And if every single insurance company, pharmaceutical plan has a different formulary. It's determined by an independent pharmacy and therapeutic committee that each plan has. And here's a pro tip. I encourage everyone to download a copy of your plan pharmacy quarterly. It should say plan formulary. Sorry, I didn't proofread well enough. And review it with your provider anytime you are changing your medications or starting a new med. So like if I'm going to my doctor, I'm bringing this app in, and I guess we're putting the names of the meds right into the app. I also found that it was really interesting in the app for my specific pharmacy provider. They also had a cost estimator, which was really interesting. So I do see that some of these drug companies are trying to make this information more transparent. We're just not quite there with where does it all live in a real-time basis. Okay, Leah. And finally, within the pharmacy coverage are two really important things for us all to understand: step therapy and tiers. Step therapy means that this is applied to a specific classification of drugs. So let's go with PPI or proton pump inhibitors, many of which are available over the counter now. But say you needed to start with a prescription drug one. You would need to start at the lowest cost drug, so at that lowest bottom step. And a lot of times language is like, you need to fail that drug. I hate that language. Let's talk about the drug failing you. And so you have to demonstrate, because you're not making any kind of clinical progress and you're still having symptoms, that that drug isn't working for you before you can move up to the next tier, which I'm sorry, I used the wrong word, next step. I don't want to get it confused with tiers because they do this and it's very challenging. So before you can move up to the next step, that drug can't work for you. And then maybe you can move up to the next one. Where do we see this in the cancer space? Pain medication all the time. And I think very much at the expense of patients who are suffering. And it also could happen that perhaps they changed prescription drug plans. They went on Medicare, their spouse got a new job, they got a new job. They might have to start all over again at the bottom of that payer's step therapy, which automatically, one, increases suffering that the patient is having, but also the amount of time it takes to get back up those steps to the medication that you were on previously. Then we have tiers, which are plan dependent, and these are tied to cost and affordability of the drugs. And each formulary drug fits into one of these tiers. This is just an example of what a tier system may look like. Yours may look different. Again, I encourage you to get familiar with what your plan looks like. On the lower end, just generic drugs, they're always going to be the cheapest option. And then in this case, preferred brand names. So there's some brands that this plan likes better than others. So they may cover those and maybe have less cost to the patient. then non-preferred brand name drugs, then preferred specialty, and non-preferred specialty. And where are we finding this to be a challenge for people with cancer? When we get into the specialty drug territory. Not only are there certain specialty pharmacies where patients have to access these drugs, and often they have to be mail ordered and sent to their homes, there can be a lot of delay just in deciding if that drug is going to be approved and covered, and if there's any other options. There's usually not. And then we have the payment issue, just the cost of these drugs, that is really impactful on patients. Okay, Lee, I think that's the end of my slide chat. Thank you.
Thanks so much, Christina. Really appreciate that level setting. So hopefully we can move on with the rest of this conversation and all be on the same page. And with that in mind, I'd like to invite everybody to weigh in one more time using our polling feature on just give us a sense of what it is that you hope to get out of this session. A better understanding of prior authorization, learning what you can do if prior authorization directly impacts your care or the care of a loved one, getting an update on where things stand with the federal policy initiatives that are currently being discussed, or learning how you can make a difference either at your local level or at the federal policy level. Or, and once again, we didn't give you an other option, but we will get some feedback in the end if there are other topics that folks would like to cover related to prior authorization. So we'll give you just a couple minutes to check in there, and then we'll move on to our great conversation. Okay, I think we've given everybody enough time. Do we have the results? Interesting. Okay. So that's great, because I think a lot of where we intend to focus today is talking about where things stand with respect to some of the conversations that are going on around federal policy. And one of the things that I want to highlight, thanks, Leah, one of the things that I want to highlight is that you're going to hear us talking a lot about Medicare Advantage. And so, Peggy, I'm going to turn to you now and ask you to first talk a little bit about why we're only talking about Medicare Advantage, and what does that mean to folks who don't have Medicare Advantage, or what is Medicare Advantage to begin with? And then I was also hoping that you could talk a little bit about why prior authorization exists. What's good about it? We just heard a whole lot of really bad things. So how could this possibly be a good idea?
Well, I'm not sure it is, but yeah, but I'll dive right in. Christina, thank you all for allowing me to participate with this wonderful group today. Christina did a beautiful job bringing it home, talking about what this really means to you. I'm going to go to a different place, which, as Courtney suggests, is about federal law. So 30 some years ago, the insurance companies said, hey, wait a minute, whenever a doctor orders something, why do I have to pay for it? And that was the premise that began the conversation about managed care. You probably heard the term managed care. Nobody likes saying that anymore because it turned into a dirty word, because what the insurers are doing is they're managing your care so they pay less money. So the premise of that ain't good when you're a patient, and particularly ain't good when you're a cancer patient. And I have a feeling many of you know this and feel this, even if you're maybe not even a cancer patient. You have a roadblock of your insurer between your doctor and what your doctor is saying you need and you. And that's tough, right? It's a really tough place to be. So you have to become your own advocates, or have people like us who are your advocates as well, or maybe even both. So I worked at the American Medical Association, and I remember as a lobbyist for the AMA many moons ago. And I remember walking in the door, and I was a kid. I think the last time I was in a hospital was when I was born. And so I'm like, what is this prior authorization thing? I had to get it explained to me as well. And basically what I heard was, this is the worst thing that happens in medicine, because insurers are not doctors. They are stopping people from getting the care that they actually need. Fight this like it is the most important issue, because it is the most important issue. Fast forward into the Patient's Bill of Rights. Some of you are old enough to remember the Patient's Bill of Rights and Clinton Care and gag clauses and drive-through deliveries and all of that stuff. I was around for those wars. And we were successful not in getting a federal bill passed, but in getting states to pass laws that stop some of those more egregious insurance company behavior. So we sailed along for a couple more years. We really, took it out of the insurance company for a couple of years there. And then the pendulum swung back, as I see it, into a place where a number of these insurance plans are again using these egregious practices to lower costs. It doesn't help that drug prices have gone through the roof again, right? So if you're the insurer, you don't want to pay a big fat bill, what do you say? Well, let's invent this crazy system called step therapy. Let's invent a crazy system of failing first with your health. Also makes me want to vomit, Christina. So let's invent this stuff so that we slow people to getting the expensive stuff. That's really what we're talking about. Insurance companies slowing you to getting the expensive stuff when it's your life on the line. So what we did about 5 or 6 years ago is we took a hard look at Medicare. So Medicare, of course, is generally for those over 65. You paid into the system, the government gives you health care. Many years ago, Medicare was also realizing that they were running out of money. So they added a component to Medicare, and that is known as Medicare Advantage. Medicare Advantage is under the umbrella of Medicare, but Medicare Advantage has components of managed care in it. So you are probably seeing commercials, or something, maybe stuff online. Sign up for a Medicare Advantage plan. It's so great. You get dental and you get vision and you get all this sexy stuff, and you're going to pay these low copays. It's brilliant, brought to you by the government. The only problem with Medicare Advantage is all of these managed care techniques and the stuff that they throw on top of you. So recent study comes out just a couple of years ago, and it says in the last 2 years of life for Medicare Advantage patients and Medicare patients writ large, Medicare Advantage those beneficiaries dump Medicare Advantage and they run back to traditional Medicare. Why? Because in your last 2 years of life, you need all those good treatments, right? You're technically dying. So it ain't good to not get the care that you need. So that should tell you something about Medicare Advantage. It's great when you're healthy. It's probably not the best insurance when you're not healthy, is another way to think of it. So we went in and took a hard look at what Medicare Advantage is supposed to be. And when it was passed into law in a bipartisan fashion many moons ago, the concept was you, a Medicare Advantage enrollee, get the same benefits generally as a Medicare beneficiary. So you're not supposed to lose anything, except for the advent of all these managed care elements. So we took that to, at the time, the Trump administration, and to the Biden administration later, and to Congress. And we started to say, whoa, this isn't fair. This isn't okay. This isn't good for the health of our country. Why are we letting these Medicare Advantage plans stop people's access to care? It's not okay. So we learned along that journey that Blue Cross Blue Shield, the insurers, AHIP at the time, those insurers had signed on to something called the consensus statement with AHA and AMA. So there's insurers on one side and the providers on another side. And they put out this really pretty document that did a whole lot of nothing. It said, we agree there's too much prior authorization and we're going to work to make that stop. Well, we held them to that. So we took that document called the consensus statement and we wrote it into legislative language, federal legislative draft bill language. And then we went back to the insurers and said, you can't oppose this, you wrote it. And they went, oh my gosh. That was the genesis of the Seniors Access to Timely Care Act. That bill in the last couple of years got 500 endorsing organizations. That's a giant number of national and state organizations who support a bill. We also put the insurers in such a box that they couldn't oppose it. In fact, some of them supported it. The Better Medicare Alliance supported it because we took their language. We took their language and wrote it into legislative language. We also had 75% of all members of Congress signed on to that bill. 3/4 of the House signed on to that bill. More than half of the Senate signed on to the bill. If that's not consensus-driven, bipartisan, bicameral, meaning the House and the Senate, kind of legislation, I don't know what is. We did everything right. We got all the right stuff lined up. The medical specialties, the AMA jumped on, the AHA jumped on, all kinds of the big groups jumped on. We were just a little specialty coalition who pulled this all together. We were this close. We got a bill passed on the House floor. All we needed was a bill to be passed on the Senate floor. But who comes in and messes it up? Congressional Budget Office. Congressional
And
Budget.
I'm gonna keep
Oh,
everybody
sorry.
in suspense on the CBO
Right.
because I've been watching Dr. Chollet smirk as you describe
I have too.
the practice of managed care. And so Dr. Chollet, I was hoping that you could talk a little bit from your perspective as a provider on what prior authorization means, both in terms of the patients that you're treating, but also from the administrative burden that it poses. And Christina, you're on deck because I'd love to hear from you and your experience talking with patients and caregivers as well. So Dr. Chollet?
Sure. So first of all, thank y'all for having me. I'm very happy to be here. This is one of my favorite topics in a not pleasant way. And my smirk has gotten me in trouble before on this topic. So that's very in character for me. So first of all, just for those joining the call, I am a radiation oncologist. I work in private practice in Nashville, Tennessee. Before I was with my current practice, which is Tennessee Oncology, I was on faculty at Duke University as a breast cancer specialist. And so I have a lot of experience with this. Right now, my practice is primarily treating breast cancer and gynecologic malignancies. And prior auth is the scourge of our practice, really. I will tell you, when I came out of residency about 11 years ago, I didn't think managed care was a bad thing. In my training, it made sense, right? Drug prices were skyrocketing. Oncology care was really expensive. We would come up with great national-based guidelines that were all scientist-based and be able to provide the best care without wasting any money. And that is what an idealistic youth I was coming out of residency, that I thought the process would go like that. That's not how it happens. In reality, what happens is that insurance companies come up with these management guidelines that are really arbitrary and are focused on the lowering cost and not increasing quality of care. So they're not going based on national guidelines. They're going based on internal guidelines of what they want to see. And that's in the step therapy that she was referencing. That's really what we're seeing. In the radiation oncology community, I treat a lot of breast cancer patients. I'd say it's about 70% of what I do. So I see probably more breast cancer patients than any radiation oncologist in Middle Tennessee. I know breast cancer. I can look at a patient's anatomy and tell what they need, and I will base all of my recommendations on NCCN guidelines or our specialty guidelines, which are ASTRO or ASCO guidelines. I'm not varying into crazy territory. And yet I would say 1 in 3, 1 in 4 of my breast cancer patients require this prior authorization for all the nitty-gritty of what a breast cancer patient needs. And I'll give it an example from the patient perspective of, I recently had a 29-year-old woman with stage 3 breast cancer on the left side. She's 29. So do I need to treat her cancer aggressively? Absolutely. But I also need to be equally aggressive at trying to spare radiation dose from going to her normal organs. So if a woman gets radiation to her heart at 80 years old, it might not be that big a deal about 10-year and 20-year side effects, but a 29-year-old, it's a very, very big deal. So I want to give the minimum heart dose necessary. I want to do imaging every day to make sure that radiation is going exactly where I want it to go. And they just denied her plan. They said, no, you don't need that cardiac sparing technique. No, you don't need to image her every day. And I called them. I said, surely this was a mistake. Nope, wasn't a mistake. They denied it. They didn't even want to hear what I had to say. They said I had to do an appeal. All right. So in the meantime, on the patient perspective, instead of getting her radiation started in 1 week, we're now looking at 2 weeks minimum. So I do the appeal over the phone. They can't take an appeal over the phone. They're going to need me to write a letter. Okay, I write a 6-paragraph letter, and it was a doozy. My nurse read it and said, well, you are feeling quite spicy today. And I said, yes, I am. And sent that letter in. It's going to be 1 to 2 weeks to review the letter. So now instead of 1 week post-treatment, we're at 4 weeks. All right, so it took actually 5 weeks. So we got to 5 weeks. Once somebody read the letter, once somebody looked at the plan, it was almost immediately approved because it was standard of care in any practice. So you've got a 29-year-old patient who's calling me every other day crying because of the delay. And then you've also got me taking hours literally to be on the phone, write letters, cite data, plus our practice now has to employ about a 0.5 FTE or full-time position per doctor to do our prior authorizations. So that's somebody that is working, 20 hours a week just for my patients. And that's somebody that's getting paid a lot of money. And then on the billing and revenue cycle side, we've also had to hire 3 additional people this year for our practice just for radiation oncology prior authorization. So you've got a patient that's getting delayed care that can impact cure, that can impact results of the treatment. You've got the emotional distress that comes with that, as well as the negative health benefits. And then you've got me getting high blood pressure and spending hours for something that should have taken anybody 2 minutes, plus multiple staff. So the burden just snowballs. And again, this is not anything that was out of line. This was not an experimental treatment, but these are the daily frustrations that we're seeing.
Thanks, Dr. Chollet. And I just want to point out, and this is full disclosure from my perspective, but I've spent a good portion of my career working on the provider side, and I'm sensitive to some of the provider reimbursement issues. And I just want to highlight that particularly in interventional radiology, there are really significant pay cuts that are going through on the Medicare side related to clinical labor costs, the same clinical labor costs that you were describing in having to keep on all of that support staff to help to adjudicate all of those issues. So I think that it's important when we think about this from a holistic perspective that we're also talking about a system that is rationing care to ostensibly to save money and cutting payments that are the only way that you all are able to negotiate appropriate reimbursement. I guess it's clinical labor, but there are other costs that go into running your practice that, these are other things that you have to consider as all of this is going on. And so certainly appreciate you telling the story of this woman who is very lucky to have you as an advocate, and for telling the patient perspective. But I think that as patient advocates, we also need to understand sort of what's going on in this entire healthcare ecosystem and the pressures that are being put on you all as providers, and sort of the displacement of priorities. So to that point, Christina, did you want to speak to anything from the patient and caregiver perspective?
Sure. I as you guys were all talking, I was thinking back to my earliest experiences with working with utilization management as an inpatient oncology social worker, and remembering that one of our biggest challenges was patients who'd had lengthy hospitalizations who needed another level of care before they could be home and safe with their families. They needed some more conditioning, they needed some more time for recovery, but they were also getting radiation, or they were also getting chemotherapy. And because of the way the payments are bundled, these skilled nursing facilities, and it's still happening today. This is like one of the things we talk about all of the time on our social work listserv. These skilled nursing facilities are paid a per diem by, let's talk about Medicare, by Medicare Advantage plans to provide all of the care for that patient, whether it's the room and board at the skilled nursing facility, the therapy services, and let's throw in the radiation and the transportation to the radiation and the chemo pill that they need. They can't do that with what they're being paid. And so as a result, patients are languishing in the hospital. And sometimes they're racking up really large bills because they're not at a hospital level of care. Their family is not prepared to care for them at home, and we're still not providing them what they need, which is to have time to get stronger so they can continue their cancer therapy. So this happens on the inpatient side as well as on the outpatient side. And as more and more cancer treatments like CAR T therapy in particular, and I've had 2 cases in the past couple months from the Helpline, both in the state of Maryland, which I found interesting. One was a Medicare Advantage, one was a commercial plan. Same treatment center, CAR T denied for 2 different diagnoses. And we had to do a lot of advocacy work, despite the fact that the treatment facility had gone above and beyond in providing all that information you talked about, Casey, and the spicy letter, which I love. We had to take it to the state both times in order for it to be approved for these patients. For the one in particular, she had a really aggressive mantle cell lymphoma that was in her CNS, or central nervous system. And the CAR T was really like the only option that they had left for this patient. And so it took 3 weeks from when I got involved to when we finally got an approval at that state level of an appeal in order for her to get approved and get admitted. So that delay in time, and Casey, I love that you brought up the incredible emotional impact this has on patients and their caregivers. The waiting is the hardest part of all of this. They want to get started. They want to get the cancer out of them in any way, shape, or form that they can, and it's completely out of their control. And here's a time when we've taken all control from patients in pretty much every way, shape, or form. They're incredibly vulnerable. And yet again, here we are taking that away from them. So from that perspective, as an advocate, I'm always thinking, and as a social worker, how is this going to impact the patient's distress level? How can we provide advocacy and support at the micro level, which is what I'm doing on the Helpline, and at the macro level, which is how can we make this different? Thank you, Peggy, for all the work that you're doing, because I hope we're making it different soon.
Well, and I want to get to both those micro and macro advocacy topics in just a little bit, but I want to pull on one little thread that I sort of set it up for Peggy. But Dr. Chollet, I did hear you say something that could sound like prior could make sense. There could be a reason why it would make sense in a healthcare system that wants to keep up with innovation, that wants to keep up with clinical standards. And so is there something that is valuable here that we should be trying to preserve? And what is that? What is that thing that what are we talking about that is a value added to the healthcare system that isn't just cutting costs or rationing healthcare? Is there something? Dr. Chollet, go for it.
Yeah, I can give an example of a time I thought prior auth actually helped me because it was with a very efficient system. You know, it was an answer within an hour on a patient. They didn't require burdensome documentation. And I got to talk to another physician very quickly. And it was a time I had ordered an MRI brain on a patient for metastatic disease to the brain. It was a very appropriate scan. And it got denied quite quickly. And I was very surprised. But again, I was able to reach somebody, talk to a human being who knew what they were talking about. And they said, oh, did you know that this patient had an MRI, the same MRI ordered by another oncologist, and it was performed just yesterday? Okay. All right, yes, I didn't know that. And that's really helpful. No, the patient doesn't need to go through another MRI. And this patient, really didn't understand. So they had showed up for the facility to get 2 MRIs done. So in that case, it saved the system money, and it was appropriate, and it was quick and didn't lead to any delays in care. And if we can get a system that works like that, that again is trying to focus on reducing redundancy and that sort of thing, I think it's good. I think it makes sense. I'm not against all prior auth. I'm really not, even though some EBICOR PBMs may say otherwise. But really, we have to get away from the insurance companies actively practicing medicine. That is not what prior auth should be.
Yeah.
How does that work? How can we make that work?
If I could have described what our bill does as well as the good doctor just described it, that's what we're trying to do. So we're trying to say one of the concepts in the bill is routinely approved services. If you, the insurance company, routinely approve something, why the heck are you dragging it out for 3 weeks? To hold on to your money for longer? That's disgusting. If you are typically approving this kind of stuff, why wouldn't you have a speedier, more timely mechanism for approving when all the right information is submitted? So as we were writing this piece of legislation, and yes, with the members of Congress, we were helping them try to figure it out. We were talking to all these other stakeholders, and they, of course, were talking to the insurance industry. The insurance industry described it this way. There are some doctors who don't submit anything. There are some doctors who submit some junky stuff. And they feel, the insurance companies, that they have to be the watchdog of making sure that it's not just whatever a doctor orders when it may not be appropriate. So we respected that in the context of writing a bill to say, you have to submit what you're supposed to submit. You have to follow the rules, but we need to have an answer. And an answer in the bill as written is, if it's urgent, it's 48 hours. If it's non-urgent, it's 7 days. Wouldn't it be nice to live in a world where you can find out on a non-urgent matter in a week? Christina, I could see your eyes rolling. How many weeks have you spent begging to get an answer on prior authorization? What if the law, the federal law of the land said it's a week? Hallelujah, we all win. If that's the only thing that passes in this legislation, that would be a giant win. There are other bells and whistles that we think are important, and much of that is about the transparency of these plans. They have to tell us how they're making these decisions. They can't just be a black box that somebody's flipping a coin, that somebody's, you're on the phone with a dentist who's telling you about oncology. No, that's not the person who should be reviewing what you're doing in oncology.
I was just going to ask you if that is included in the bill, because I wanted to say that in my CAR-T case, it was a pediatrician.
Okay.
It's a qualified medical specialist is what we have in the bill. And before I go here, Courtney, if you want to go somewhere else, I do want to talk about what the administration is doing and how they've taken our bill and ran with it.
Let's go. Because I was gonna ask Christina if she could think of a way that, my typical story is, I work in health policy. My sister is a pediatric oncologist, and sometimes we get flummoxed by the healthcare system. And so I was going to ask Christina if she had encountered any cases where prior auth could be beneficial. And she nodded and shrugged. So
she wasn't audible, but I heard that sigh. Yeah.
So Peggy, I think let's go to big A advocacy. But I want to hold space for little A advocacy as well. And so Christina and Dr. Chollet, be thinking about what can patients and caregivers be thinking about doing as they're encountering these types of situations? How can they advocate for themselves, and how can they help you as a physician? But Peggy, so where are things now? You got us through last year, and we were this close. So what the heck happened?
So we got a score. And so there is this.
What is a score?
So the group called the Congressional Budget Office. And anytime a bill is moving in Congress, this group comes into the fray, the Congressional Budget Office, and they decide how much a bill will cost the taxpayers of America, right? So they looked at our bill and said, we find $16 billion of cost. And we went, whoa, hold on. If you had listened to Dr. Chollet, am I saying that correctly? Chollet, yep. You would know that there are inefficiencies built into the system where you have to hire all these people to check prior authorization. So it should be less of a cost if you're doing prior authorization fast, but that's not what CBO found. That's what doomed the bill last year. But what happened at the end of the year is that the Biden administration grabbed our bill and wrote it into regulation. So there is now a pending several regulations that are clamping down on Medicare Advantage in particular, and other kinds of insurers like I've never seen before. In 30 years doing healthcare policy, I have never, ever seen this many regulations, and our bill have the strength of pulling managed care back in and reining it back in.
So how do they do that? So, I mean, we all know how a bill becomes a law, and then, you know, the administration is responsible for implementing it. So how did they just come up with this and say, oh, this is the law now?
So the regulators have what they call regulatory authority. They have authority right now to look at the Medicare Advantage program, the Medicare program, and anything else the federal government runs. The Children's Health Insurance Program, those programs are federal by nature. So regulators have in law already the ability to regulate those programs. They use that existing authority without our bill being passed yet, and they took literal language out of our bill. I mean, it was really thrilling to kind of see my words show up in a regulation. That happened. They knew we were onto something. They grabbed the language from the bill and expanded on it in a beautiful way. So they do what's called a formal notice and comment rulemaking process, where they put out a proposed rule, and then everybody weighs in and says what they think about it. And eventually they put out a final rule. So that final rule then becomes law by virtue of the regulatory authority, and regulations are published. So you wonder, Peggy sits here and says, well, hell, the agencies, the Centers for Medicare and Medicaid Services, are already doing what you put in that bill, Peggy. Why would you bother passing a bill into law? I want a bill into law so that some crazy next administration can't come in and change things. A law is literally an act of Congress, law of the land. It has far more power than a regulation. We need by the end of this year, yes, those regulations are going to lower our cost from CBO, because CBO told us it would lower the cost, making it easier for us to pass the law. And then you have the force of law when we pass our bill into law. So complicated, but there's two actions, or two agencies really acting here, two bodies acting here, the agencies and Congress, and we need both of them. So the latest missive we've got out there is the House and the Senate champions on the bill. So all the senators and all the representatives who led our bill last year wrote letters to CMS. They're sending them to everybody else on Capitol Hill and saying, please sign on to this letter. What does the letter say? It says, hey, fellow senator, sign a letter to CMS saying, hurry up and finalize these regulations. They're good. They're good, and they match that bill from last year, and this is what we have to do. So our big effort right now is not to go pass the bill right now. First, we want to get the finalized rules, or the rules finalized. So we're using, in a kind way, members of Congress to agree with that concept, ask CMS to hurry the hell up, pardon my French, and then we can move on to passing the bill later in the year. That's the strategy, that's the plan. So if you're advocating with Congress and talking to anybody in Congress, all you need to say is there's a CMS letter on prior authorization. I need your boss to sign it. That's what we're doing right now. We get a groundswell of people signing on to that letter. CMS hurries up. We keep the momentum up. We pass the bill, I hope, by the end of the year.
So, Peggy, that's really great, and that's something we will definitely follow up with everybody on this call to make sure that they have the opportunity to weigh in with their members of Congress to support that letter. Once those regulations are finalized, do you think that will have any impact on that CBO score?
Yes, in fact, we know for a fact that at a finalization of a rule that is directly on point with the bill, we get half off. It's like a BOGO sale, right? I would get one free. We get half off. So that 16 billion awful, dumb, horrible number comes way down. It could come down by half. It could come down by more than half. And then we might have to tweak the bill language a little bit to get it to be lower than that. We have commitments from the Republicans and from the Democrats. They really want to do this by the end of the year. We just have to help them do it. If they have to find some millions of dollars under the couch cushions, we're going to ask them to go find those millions of dollars under the couch cushions, because this is that important to get done.
So you have agreement from Republicans and senators Republicans and Democrats in the House and Senate to do something.
Right. The catch is you can't get enough fiscal conservative Republicans to agree to spend a big bunch of money. They cannot go home to their constituents and say, I just spent $8 billion. Because their constituents will say, remember, you're a fiscal conservative and we didn't want you to spend our taxpayer money. That's the political consideration. We know the other side of that is you're going to save money to make money and save people's lives and help people. And that's important. Sometimes it's a good thing to spend money, but politically it's very tough for fiscal conservatives to take that big of a hit in how much they've agreed by signing onto a bill to pay for.
So Peggy, one last question, and then on Big A advocacy, and then we're going to turn to what happens to folks who are trying to get treatment right now. You talked about some of the efficiencies in the bill and some of how we're hoping that prior auth will be stemmed or used more effectively as it was intended in the Medicare Advantage program. So can you just outline what specifically those policies are, what it is that the bill is going to achieve when it's passed?
So we have so much more on this at regrelief.org, regrelief.org. So if anybody wants to go to that website, you will see every letter we've written, everything we've said. I've told people everything but my shoe size is on that website. It's the bills are on the website. You can actually read the bills. They're not that complicated. You can read our summaries of the bills. You can read reports about the bills, gobs of stuff. But in a nutshell, because we're on a Zoom call, we don't have tons of time, I'm going to do 10,000 foot. 10,000 foot is this bill has really two components. The main component is electronic prior authorization. Why the heck in 2023 are we not doing electronic prior authorization? If you're faxing things from a doctor's office to an insurance company, it's not 1983. That is ridiculous. We should not be doing any of that, right? Electronic prior authorization it should be a requirement for insurers. And if doctors who are, let's say, older aren't doing that, that's okay. We'll let them for a minute. But the insurers are going to be able to accept electronic prior auth. Electronic prior auth will change the game. The second thing is the other big component of the bill is that the insurers have to tell us the rules. They have to say, this is exactly how we do prior auth. It's not going to be that black box, make it up garbage anymore. So those are the main two components of the bill, but I do encourage you all, take a hard look at that website. The routinely approved services thing I talked about, the medically qualified specialist who's reviewing a doctor's decision, not somebody who is the podiatrist talking about oncology, all of that is in there. There's many facets of this bill, and sorry to give it such short shrift, but there's a lot in there that I think will do a lot of good. And I joked earlier that the doctor was saying, here are the 6 things that make it work. Well, those are 6 of the main components of the bill. Timely, getting information in a timely fashion, getting to know what the rules are, to know what the processes are. What do you want from me? What do you want? What are your requirements? To submit guidelines. When you've got guidelines for your particular specialty, you're not winging it. You're not making it up. People have spent years analyzing the medical science for that moment in time and that medical level of acuity or, level of medical science at the moment. And then the insurers ignore it. The bill says you ignore it at your peril. It's not okay anymore.
Thanks, Peggy. That's really great. And we'll definitely share that information with everyone who participated on this call and make sure it's on the CSC website. I do want to make sure that we also, and we only have just a few minutes left, but for those who are able to hang on with this, I'd love to, I want to make sure that we focus on what can you do if you are a cancer patient right now, or a caregiver, you have a loved one who has recently experienced a cancer diagnosis and you're potentially going to be faced with prior authorization challenges. I think Christina gave some good tips on how you can prepare yourself, arm yourself with knowledge and arm yourself with details from your plans. And Dr. Chollet talked about how she, was a really great advocate guiding her patients through this process. But both of you, Christina and Dr. Chollet, what do you recommend as sort of, I'm going to call these little a advocacies, but it is your own personal advocacy, and it is no less important. In fact, it is extremely important to how you achieve your treatment goals. So Christina, go ahead.
Ask for help. 100%. I know a lot of people don't like to ask for help or feel like, I know I'm a fiercely independent, autonomous person myself, but there are folks out here with knowledge, with connections, whether we like it or not. There is a network of folks who know folks who know folks. So ask us for help. We want to be able to do that, whether it's at your institution where you're being treated. Ask the social worker, ask the navigator, ask for the financial advocate. We are also available at the cancer support community to help with this process. But I think that's one of the things that when I'm as a provider and I talk to other providers, a lot of times we don't know there's a problem, especially when it comes to prescription drugs, because we give the patient a prescription, they go to the pharmacy, it's $4,000 and needs a prior auth, and the patient's like, no. And then we don't know that they don't fill the drug. And patients are feeling like, I don't want to tell them I couldn't afford it, or I'm taking half the meds to spread it out. We have to have these conversations with our providers. Don't be embarrassed. I know it's easy for me to say it, but it's really important that they know the barriers that you are facing when you're trying to access care so that we can help you.
Dr. Chollet.
Yeah, I'll echo Christina's comments, the importance of communication. So yes, reach out to help if you have any local advocacy organizations, but also communicate with your physician, their nursing team. I prescribe the medicine. I have no idea if you don't get it unless somebody tells me. So I just had a patient I met with this morning who I prescribed a medicine that was just a mixture of some generic drugs that were meant to calm his throat, getting radiation. And Walmart told him it was going to be $800 for a bottle this big. Probably cost him $5 to make. And it just wasn't covered under his formulary. So then we had to do some digging to find out what could get covered. And what we ended up doing was prescribing 3 strep throat generics and telling him how to mix it. And that cost him $10. Should he have to do that? No. But we got him the medicine within a day, and he had been without it for a week, and I had no idea. So communicate. If your physician does tell you, say on the radiation oncology side, that there is a timing issue, that they are appealing something, feel free to reach out to your insurance company directly. Ask for a patient advocate. Do it both on the phone and in writing through email or letter to let them know how this is impacting you. And also, don't be afraid to get on social media and explain your challenge, name the insurance company and what you're seeing. Tell these stories. I'm a big advocate for both physicians, social workers, caseworkers, and patients getting on social media platforms and telling their story and how they're being impacted, because a lot of the non-oncology community, the non-cancer community, they have no idea what we're going through until it faces them, and they will advocate for you. So that would be mine.
And I would add to that you also have members of Congress who are considering legislation, who also have district offices and caseworkers whose job it is to help you to navigate these issues. So, in addition to that social media campaign, I would suggest reaching out to district offices of your members of Congress, both senators and your representative, and asking their caseworkers for support. If nothing else, it will drive them to pay a little bit more attention to the larger, to the big policy issues that are being discussed right now. But it could also help to get some attention to your individual concerns. So I just want to thank our panelists so much. I really enjoyed this conversation. We have 2 more topics two more polling questions that I'd love to put on the screen. The first is, based on this discussion, what actions are you likely to take? We saw from the various stakeholder perspectives, or we saw the various stakeholder groups that were represented in participants on this call. So it'd be really interesting to see how these responses come together. In addition, thanks for putting them both together, Leah, and Dawn, who are backstage and making sure that all of the trains run on time, and my thanks to both of them. They compiled the second answer as well. What additional topics would you like to see us cover in this webinar series? So we'll give you just a few seconds. Again, my thanks to these awesome panelists, and I hope that you won't mind if we pull you in again for future conversations, because I think that we have some really important topics coming up. We will continue to talk about step therapy. We will continue to talk about other utilization management practices that may be able to be redefined in a way that is helpful, but they're certainly not necessarily helpful now. So Leah, let's see those responses. Excellent. So we have a lot of folks who are interested in reaching out to their members of Congress. So we will make sure to get you all of that information, and look forward to having you continue to be a part of our grassroots advocacy cohort as we go forward. We got a couple of responses on the future topics that we'll consider. Thank you again so much for your participation. Thank you again to the panelists, and hope everyone has a great afternoon.